And thank you for joining us for today's webinar topic, keeping students safe, testing for COVID while limiting its spread in schools. My name is James Collins. I'm the Senior Director of Business Development for CSBA, and I'll be facilitating today's webinar. Before we get started, I want to make a few quick announcements. If at any time you have questions for presenters or technical issue, please use the questions tab of your GoToWebinar dashboard. If you do not see the webinar dashboard, it may be collapsed. Look for an orange arrow in the top right of the corner of your screen. Click on that arrow and it will expand the dashboard. At this time, I would like to introduce our presenters for today's discussion. John Dietering, CEO, Maclean Group. Tony Campos, CEO, Maclean Group. Mike Smith, Executive Vice President, AMI Health, representing the virtual team you see on your screen soon. Robert Naus, Chief of Staff, Testing and Vaccination, LA USD. And Paul Shalla, CEO, Delos Air Purification. And lastly, Jeremy Ellis, founder and CEO of TrackMy Solutions.
Good morning. Thank you for joining us. I'm John Dietering. I'm the CEO of Maclean Health. We partnered with CSBA earlier this year to ensure that school districts had reliable access to healthcare consumables like face masks and other healthcare supplies that they may need to safely have school. So we are the current holder of the California statewide face mask contract, and as part of our partnership with CSBA, we offer that contract pricing and all of the great terms that come along with that contract to all of the schools across California. Today, we are here to introduce two of our partners, Delos, the world-class air purification manufacturer. Paul Shalla, CEO, will be presenting, and then AMI Expeditionary Health. They are the preeminent testing and vaccination service provider in the country, and they are currently doing over 250,000 tests a week for LA Unified, so offering their services here to the rest of school districts across the state. With that, I'm going to turn over to Paul Shalla, CEO of Delos.
Great. Thank you, everybody. I want to make sure I'm coming through clearly. This is Paul Shalla, founder and CEO of Delos and founder of our International Well Building Institute. Next slide, please. It's a pleasure to be speaking with you all today. We have been merging the health sciences with the building sciences for about a decade. And the first 5 years of that, the first half of that effort was all research. Over $100 million of our capital was put forth in a massive research effort, pulled in the world-renowned Mayo Clinic, Cleveland Clinic, and hundreds of doctors of different disciplines, got them together with real estate professionals of all types, owners, operators, developers, facilities managers, architects, engineers, HR professionals, basically guys to best understand our indoor environment and its impact on the human condition. We all spend over 90% of our lives inside our schools, our homes, our offices, what have you. And what was needed was an evidence-based approach to connect the built environment with occupant health outcomes. Over that 5-year period, we went deep on everything you can imagine that surrounds people indoors. Air quality, water quality, lighting, thermal, acoustics, biophilic elements, surface and cleaning protocols, HR policies, operational guidelines, mapping all of these elements directly to our respiratory, cardiovascular, immune, cognitive, digestive, and sleep health outcomes. The ensuing body of work in 2015, after a 1-year medical peer review globally, led by Cleveland Clinic, was introduced as the Well Building Standard through our International Well Building Institute. That is today the world's largest third-party verified certification platform for healthy buildings. It's in over 100 countries, every typology included, Fortune 500 corporate headquarters, mom and pop bakeries, airports, schools, libraries, hotels, restaurants, basically anything that's got 4 walls, a roof, and a front door can adhere to the Well Building Standard. The reason I'm giving you that background is we are a standard-bearing organization, the world's largest as it pertains to human health in the built environment. And once that governance was put in place, Delos at the enterprise level 5 years ago went further, zooming into very specific products, solutions, technology that are good health interventions for any type of space, whether that's a bedroom, a living room, a school classroom, a hotel room environment, an office environment, air filtration technology, water filtration technology, circadian lighting technology, and active green wall technology, among others. For the last 5 years, Delos has taken a product agnostic approach first across the spectrum of all solutions. All of you folks, by the way, thank you for your service. And all of you folks have been put in an unfortunate position with the onset of this pandemic as it pertains to, I'm sure, having so many different companies and vendors and manufacturers coming at you with their air filtration technology and solutions. We are, number one, a source of clarity, a voice of authority, separating fact from fiction. Over the last 5 years, Delos has examined over 100 different types of technologies, products, all the types of air filters all on the market, all the different types of methodologies, bipolar ionizers and UV light, UV elements, the electrostatic precipitators. Basically, every company approaches us, large and small, as a standard-bearing organization and a deep lab research effort, which I'll get into a second. They want our approval, our vetting, our laboratory testing, and ultimately Delos sees everything. When we do find something we feel is appropriate, we'll go further. In some cases, contributing IP, putting it through very rigorous understanding of true efficiency. And there's a lot of terminology out there that are confusing people, whether it's HEPA or MERV or what have you, which I'm going to get to in terms of clarifying all this. But Delos lands on best-in-class technology, aggregates a ton of demand in the system, and just in the last 7 months alone, we have become the nation's largest solution provider for air filtration into public school classrooms. New York City, DOE, Chicago, Boston, Baltimore, even LA Unified now starting to order product. But the key here is we've put over 250,000 standalone air filtration solutions into public schools around the country. We're seeing a lot of incoming now as schools are getting their funding, which these fully qualify for. And I'm going to get into the deep-rooted science and the scalability and the affordability of what we found to be a best-in-class product. As mentioned, for the last 5 years, going very deep, understanding the pathogen concern that we have today, understanding the size of this pathogen concern, and what is effective filtration versus only partial or even reckless claims that are made out there with regards to the different types of units and filtration elements. So if you could move, actually, let me speak a little bit more on this slide. The other element that's important here is a 50-50 founding collaboration Delos has with Mayo Clinic. As you all may know, Mayo is a top health institution on the planet. We actually created something called the Well Living Lab on right adjacent to Mayo's campus in Rochester, Minnesota. That is a research facility we own and operate. It's the world's only facility that allows us to simulate indoor environments and test true efficacy of various health science interventions. In this case, we built a classroom, about 1,000 square foot classroom, with all the desks, the chairs, mannequins simulating teachers and students, breathing simulators, cough simulators, the top aerosolized particle experts in the world, including Mayo virologists, and effectively demonstrated a pre and post intervention with this particular air filtration solution that showed phenomenal results, a 5-factor reduction of indoor aerosolized particle transmission risk, and even the highest risk scenarios where you've got 2 students sitting right next to each other, unmasked, and one contagious, if you will. We showed great results with regards to reducing surface residuals, where particles are actually getting caught before they land on surfaces. And effectively, I'm going to get into the technology here that happens to be, after seeing everything, and we can tell you the good, the bad, the ugly with any product on the market, but after having seen all these technologies and putting them to test, this particular solution happens to be the most scientifically rigorous and proven, the most scalable, can fit into any classroom, any building, any age of building, small, large, new, old, does not matter. No complexities with HVAC, no labor, no renovation, so very scalable, standalone filtration solutions, portable, wall-mounted, what have you, and also what we found to be by far and away the most economic. If you could push to the next slide. Thank you. So what we're talking about here, guys, is a device the size of a small fan, plugs into the wall, gets you 99.97% reduction of an airborne viral load down to 0.007 microns. That's about 40 times smaller than where a HEPA, in terms of particulates, than where a HEPA rating will be. The industry has unfortunately been thrown a lot of terms: MERV 13, HEPA, and again, a lot of different methodologies. And our job here is to separate fact from fiction and put forth, again, best-in-class solutions that we know have been tested in real classroom settings. And what we've landed on, again, by far and away, is this particular technology. You've got this device, can plug into a wall, can be wall mounted, can be floor placed. They're very quiet. There's very low maintenance. You're dealing with a 1-year annual filter replacement, and they're highly affordable. These things scale at a couple $100 per classroom. In general, what we have been prescribing is 2 units in a classroom, placed one on each side, which localizes filtration. And this is very important. What we have and what we're facing today, guys, is an ongoing pathogen concern, as you all know, that continues to mutate. And, Delta, in my mind, is not even the issue. Obviously, it's a problem. But I think what we're really dealing with is what comes after Delta. With 10% of the world vaccinated, these mutations are inevitable. And whether we're 1, 2, 3 mutations away, we're going to be dealing with a lingering issue here. And this pathogen concern needs to be addressed. Getting filtration in your HVAC, whether you're able to upgrade to a MERV 13, which would be phenomenal in terms of the farthest you can go in terms of what a energy load really could handle in the ducts, that's only going to get you about halfway there with regards to true aerosolized particle reduction and filtration. What we need to do is localize filtration. You need to address the problem as close to where people, students, teachers, what have you, are, where respiratory droplets are occurring. So we believe that the future of ultrafine particle filtration and the way to truly address ongoing pathogen concerns, not to mention everything else, mold, spores, toxins, pollutants, dust, smoke, what have you, jet fuel, what have you, we believe that the future is standalone, is to localize filtration. By applying 2 of these devices, and there are different sizes, which I'll get into, but 2 compact devices in any classroom, regardless of what you may or may not have done or able to do in the duct, will get you equivalent to a MERV 20 efficiency, localized, 100% localized, and get you 99.997% reduction at 0.007 microns. A HEPA rating will rate a filter at 0.3 microns. We're talking about 0.007 microns, and for reference, SARS-CoV-2 particles are about 0.08 to 0.14 microns in size. So effectively here, what you've got is localized filtration, very scalable, very affordable, and something that has nothing to do with upping the burden or the load, the energy load on an HVAC, and has nothing to do with the complexities with regards to older buildings that can't even get to a MERV 13, if you will. So at this point, over 250,000 of these units have been deployed. Again, as mentioned, some of the largest districts in the country. I will reference New York City DOE started early, started to order these units and continue to come back for more. And the feedback's been phenomenal. Across the districts that we speak to, generally common feedback are as follows. First of all, we trust you. As the world's largest standard-bearing organization, you wrote the well building standard. You put 10 years of effort into this, 5 years of straight research, truly understanding the indoor environment and its impact on the human condition. So we like that you're a standard-bearing organization. We love the fact that you actually have your own laboratory facility, founding collaboration with Mayo Clinic, and that you've gone so far as to test and build out classroom settings to truly verify efficiency. That, by the way, study was featured on Good Morning America a few weeks ago. That revealed the results of that study. And the general feedback continues with regards to this narrative. What you guys have shown us here, and we've seen a lot of different solutions, what you've shown us here is by far and away the most scientifically rigorous and effective and proven and tested, number one. Number two, by far the most scalable. These can be placed into any room, any classroom, hallway, nurse's office, gymnasiums, auditoriums. There are larger size units that cover even larger square footage, up to 3,000 square feet of coverage with one unit. So very modular, if you will, and scalable in that sense. And lastly, by far the most most economic. For that type of filtration, the comparisons are much higher. So we're super pleased to be able to serve a role here. As we have aggregated so much demand, we've been able to drive down supply chain pricing and get these into school districts, whether you're ordering 1 unit or 10 units or 1,000 units or 50,000 units, getting these into the system all at a uniform price that is really, really beneficial to get these out into the system at scale. We expect millions of these units to be installed throughout the country. Candidly, I feel like most schools are getting a late start here, obviously late August, as kids are returning. But the good news is you don't need to worry about a lot of time drain here. Once these things are ordered, we've got hundreds of thousands of units in inventory. These can be sent in a matter of days, 3, 4, 5, 6 days. Plug and play, simply a drop ship, take them out of the box, plug them in, wall mount them if you like, and you've got the solution. So it's not a heavy burden with regards to labor or renovation or having to really go through a heavy process here. So we feel like this solution. Also, we know that these units have been in the system for upwards of 10 years and running. Some great clients across bank institutions, New York Health and Hospital, for instance. So healthcare, banking, retail, education, residential, these are applicable anywhere, basically. So with this mechanism of action in place, we effectively got started super early. I would take this back to maybe February of last year, when the world started to focus on hygiene and surfaces, and candidly, a lot of hygiene theater, overcompensating with regards to surface cleaning. Our doctors, our virologists, our task force, led by U.S. Surgeon General Richard Carmona and Dr. Stacy Riza, Chief of Staff up at Mayo Clinic, they recognized early that this is something that's much more of an airborne issue as opposed to a surface-borne viral load. And our task force of over 500 virologists, behavioral scientists, public health experts, all folks who helped us inform our health safety rating, again, recognize the importance of aerosolized particle transmission reduction and the fact that this is really airborne. And the biggest carrier of this viral load is indoor air quality. So we got started early, we got way ahead of supply chain and are able to deliver mass quantities of units at super discount volume pricing for anyone ordering any amount. And again, something that we know is the best-in-class solution. And our hope here is that school systems across the country continue to take this up, because there's a lot of money being wasted. Folks are going so far as to upgrade MERV 13 in their ducts and think they've finished the process. As mentioned, we believe that gets you about 50% efficiency at best on pathogens. It's not localized. Air's got to travel a long way to get into those ducts and get filtered. You need to localize this. So it's a great supplement to things you may have done, or as a standalone solution, this is getting you that MERV 20 efficiency without any issue on your HVAC burden, what have you. What I would like to say is we'll obviously answer all questions after the webinar is complete. We thank Maclean Group and CSBA for the opportunity to be in front of you guys, and certainly keep up the great work you're doing. I know it's not an easy environment for anybody, and we are here to serve. If by chance you are looking at any product solution, again, as a standard bearing organization and with a laboratory platform with our Well Living Lab and our Delos labs, we will provide you a third-party evidence-based opinion on any product. That's our job first. And we want to be an open resource to any of you guys. If you have questions, if you're looking at other types of products, we will return an answer within hours on any device, any product, any methodology. It's what we spent the last 5 years doing. And believe me, we know the traps. We know the claims. We know the reckless claims. We know what's effective. And we know what's actually going to be effectively a waste of money. Last thing I'd conclude with is, yes, we have a pathogen concern, and this pandemic will come and go, and others will come and go. But the benefits to ultra purified air quality in a classroom, this is something that is a decades-long problem and is something that has an opportunity to take a decades-forward approach to connecting the importance of indoor air quality as it pertains to cognition, mental acuity, test scores, absenteeism, asthma rates, influenza, and oh, by the way, SARS-CoV-2. So thanks everybody for the opportunity to give you some information today, and we look forward to answering any questions you may have at the end. Thanks, guys.
Hi, I'm Mike Smith. I'm the Executive Vice President for Testing and Vaccination Division of AMI Expeditionary Healthcare. Oops, here we go. Good. Hi, I'm Mike Smith. I'm Executive Vice President, Testing and Vaccination Division of AMI Expeditionary Healthcare. I, along with my teammates, will be today Robert Naust, Project Manager, LAUSD, Dr. D. Zafari, who's the Chief Medical Officer for Testing and Vaccination, and Jeremy Elias, who is the CEO of TrackMy Solutions, which provides us with the healthcare information management system that we use on some of our projects. I'll act as the MC and hand it off to the various team members as we go into greater detail about AMI's capabilities and experiences. Next slide, please. AMI, what we do is we offer turnkey solutions. We can do and meet any requirement that a customer has. We design specific programs to meet those unique requirements. We've worked with various states and counties all across the U.S. States we've worked in are Wisconsin, Pennsylvania, California, just to name a few, and then larger counties all across the U.S. To date, we've delivered over 400,000 vaccinations and administered over 800,000 COVID tests. Now we're ramping up to do about 250,000 tests a week just in LA alone. Next slide, please. So AMI, we've been in business since 2012. We were part of the Ebola response in 14-15, supporting USAID. I was actually the country director for that project, and later on I'll introduce some more of our key personnel. Dr. Tom Crabtree, retired U.S. Army Colonel Surgeon. He was the Chief Medical Officer for that project. We were part of the initial Department of Health and Human Services response to COVID. We responded in Washington State when COVID first got into the U.S. And since then, we've deployed thousands of clinicians across the U.S., Caribbean, and Africa doing COVID response. And even now, as the Delta variant rates of infection pop up, we've just deployed 380 clinicians down to Louisiana to help staff their hospitals there. Dee, can you talk us through Summer Bio a little bit?
Yep. Hi, everybody. Dr. Zafari here. As we know, as more vaccines become available or within the hesitancy and with our current wave number 4 or 5, whatever you want to call it, we do know that diagnostic testing will continue to be a critical part to guide COVID-19 treatment and surveillance, as well as reopening of businesses and schools. With that being said, AMI has partnered up with Summer Bio, which is actually a California-based CLIA-waived laboratory that runs thousands of testings across the state in multiple venues. One of its primary clients or customers right now is us, along with Summer Bio. We service LAUSD, where we do about 250,000 tests a week currently to make sure all the students and staff for LAUSD are being tested. What makes Summer Bio quite unique is that it does individual PCR testing without the need for pooling at a very economical pricing. And it has designed an automated identification recording system that simplifies the collection process as well as the reporting mechanisms behind it. And individual results, about 99% of those are readily available within less than 24 hours of specimen collection. And their rapid PCR testing allows for a very high, accelerated and accurate high volume testing based on the client needs.
Next slide, please. So AMI's value proposition, or what we bring to the table, is that both our testing and vaccination solutions are proven. We've proved them in many projects across the U.S. and abroad. we like to call them adaptable, scalable, and flexible. We can adapt to unique requirements and provide a solution very quickly. We can ramp up to meet the requirement. And if the level of effort goes up, we can ramp up with additional resources. And then if the demand falls off, then we can scale down very quickly. We like to say we're flexible as well. We can modify the approach in the middle of the project and adapt to new requirements, or work with our customer to define new requirements and meet solutions. We're able to offer a cost-effective contract mechanism with our customers, and almost every customer that we've dealt with really likes that approach, where they only pay for what they use. And basically, it's really two contract line item numbers: one for labor, which is time and material, and the other is for everything else, which is, we like to use it on a cost-plus basis with very transparent pricing. We're also able to offer not only static or staff static locations or set up static locations. We can do mobile teams and pretty much go anywhere. Hence the name Expeditionary. And we provide dashboards to our customer on a cloud-based system so that you have access to the information you need in real time. Next slide, please. All right, Robert, would you like to take us through LAUSD project a little bit?
Happy to. Good morning, everyone. Robert Naus. I'm the project manager for the LAUSD project that AMI is doing to test about half of LAUSD students. So we began our project in April with just under 500 staff, and we have grown that significantly to just under 900 staff at the moment. So we have scaled up significantly and can do that on quite a turn of a dime basis, if you will. Our ability to staff up from approximately 15 to 20,000 tests to now we're currently doing 50,000 tests per day, which equals about 250,000 tests a week. We're able to scale up within 2 weeks. In addition to mobile testing, we are serving 6 of LAUSD's static sites, which include parents, teachers, administrators, as well as ancillary staff. We also have a team that services about 100 homebound students that are provided in-home instruction by LAUSD. So that gives us an ability to go through all 6 districts and really touch those that are the most affected by this problem. We're really proud of our partnership that we have with LAUSD, and in the end, LAUSD's testing provides about 10 to 15% of the COVID testing that's going on throughout the nation, of which we cover half, if not more. Happy to answer any of your questions at the end.
And just to look at the clinical aspect of the magnitude of this project, what AMI has been able to do along with our partners is provide the turnkey solution, as well as making us the premier testing company when it comes to school and universities across the country that we've been able to open up for customers. We have created a clinical hierarchy that makes us quite unique in this venture, in that there's multiple layers of oversight, starting from our on-the-ground teams all the way up to our field PMOs, then to our headquarters PMO. And each level has different level of clinical oversight to make sure that we are staying compliant and enforcing appropriate infection control mechanisms, that we work seamlessly with our customers. And in this instance, it would be LAUSD, or in other states, it would be the customers at that site. Our team members are constituted different levels, starting with medical assistants, EMTs, CNAs, up to mid-levels, as well as physician-level oversight. And we have the ability to provide a full clinical governance if needed by our customers, and where we come in and we can provide everything from contact tracing to the actual testing, to the training, to mechanisms about reporting. Next slide. And just to delve in deeper into what AMI can offer in terms of testing, we realize that California State may possibly try to use a pool testing option, which initially, when we're not in a peak, may be suitable. But what we can offer and the levels that are unprecedented with our testing partners is individual PCR testing. And what that means is our staff are clinically trained to provide that level of support in any region or space you can call it. And we have the ability to do it inside school buildings, inside business buildings, and provide strike teams, or what we call mobile teams, for homebound students and or teachers. And what that means when you talk about individual versus PCR, what we can offer is the individual specimens are taken from each individual student, staff member, or ancillary staff. And that individual specimen gets, if there's a positive result, they automatically get that result. Or if it's negative, same way, the individual person as well as the customer gets those results. And that's in a 24-hour or less for every individual. Now, the benefits of doing individual testing is that it's fast, it's reliable, and you can actually detect individual COVID-19 positive cases for contact tracing as well as preventing the spread of COVID-19. When you talk about pool testing, just to on a 10,000 foot level, pool testing takes multiple samples and runs testing based on those tests. What that means is that when that sample, that pool sample, if there's a positive result in that, then it needs to be retested to determine who actually is positive. Now, some people have said that this is good in that it can help reserve some chemicals, some manpower, and or resource restricted areas. But in reality, this can actually be kind of cumbersome and financially unreliable in that if you are at a high prevalence state, and Mayo Clinic and CDC have said the cutoff for pool testing may be around a 2% positivity rate within the community, this does not become cost effective, and it becomes labor intensive and actually becomes quite a restriction on the laboratory to run so many pool testing if there's one positive rate. So that's the difference between what we can offer and what pool testing does. And at this point, because of our current wave and in the pandemic that we are in right now, individual PCR testing is the recommended mechanism to keep schools open and maintain a degree of low levels of COVID-19 in the schools and in the communities.
Next slide, please. I'm going to talk a little bit about our past performance and experience. And actually, that's my daughter getting the vaccination over there in the top box. One of the projects that we're very proud of is the Pennsylvania Department of Education, where we were asked to come in and help vaccinate 112,000 teachers and to do it quickly. So we deployed about 700 people across 28 sites and then got them all vaccinated within a 3-week period. And Pennsylvania was very pleased with that, and it allowed the teachers to go back to school and open up the schools again back in April of this year. We've been working with the state of Pennsylvania, Commonwealth of Pennsylvania, actually doing testing since last September. Started out pretty small and expanded into 5 teams, actually testing a lot of the counties that don't have their own departments of health, and we would move amongst the counties. Now we're sending out mobile teams and doing pop-up clinics at multiple sites. I think we're doing everything from universities to welcome stations in the state. We've been working with Bucks County, which is a large county right next to Philadelphia, with their emergency services, and we started out in December doing testing, and then within 3 days we converted over to vaccination once the vaccine became available, and we administered over 1,300 doses, right? And we've also done probably, I say 5, 6, 7, 8 sites. We've moved around to various locations, everything from malls to community colleges. We're working with the Department of Health Services in the state of Wisconsin. Again, we started out with mass vaccination clinics, and now we're doing multiple clinics, and we're at the state fair administering vaccinations there. Next slide, please. I'd like to turn it over to Jeremy now for him to talk about the healthcare information management system.
Thank you, Mike. Appreciate the time, everyone, for allowing us to talk through Track My Solutions and our healthcare management platform. Appreciate AMI and CSBA for the invite. Track My Solutions has been a trusted partner with AMI, both in the US and internationally, since the beginning of the pandemic, and a world leader of patient engagement solutions related to COVID vaccine and testing. Our platform expands from lab results, vaccine administration, and now the much needed vaccine verification. Our focus is to enhance patient safety and save lives through technology. We partner with AMI and other partners across the nation with an easy to use platform for patients, students, staff to register and schedule, receive those lab results digitally directly to the patient through our patient portal, and create what we call an e-lab result passport. Within that passport, it has the verification of the positive or negative COVID test result, allowing for schools and such to take next steps per their appropriate policies. We also have provider workflow from a testing administration perspective, built with efficiency using barcode scanning for rapid check-in and processing. So we could do those large volumes, as Mr. Robert Naus was mentioning earlier over there in LA USD, and Mike mentioned in Bucks County. We have localized state and regional reporting and analytics for total tests used, total positives, negatives, etc. The platform is built with HIPAA in mind, meeting HIPAA compliance and security-based standards. It's all built within the AWS cloud encrypted platform, very scalable to meet all of our clients' needs. I really like what Mike mentioned there is we come in, listen to our clients. We're very flexible and scalable to meet any and all of their needs under a obviously high pressure environment. We also have third-party billing integration and full claims processing built in, should we want to go down that route. And we have a rapid implementation timeline. As Mike mentioned there with Bucks County and with Pima, we actually were deployed in about a two to 3 day period to stand the platform up and start capturing vaccination and testing details. Appreciate the time. Going to keep it short here. Happy to discuss additional questions at the end. Appreciate it. Next slide, please.
So just to talk a little bit about some of the personnel that we have on staff, I mentioned Dr. Tom Crabtree. He's a retired U.S. Army surgeon and worked on the Ebola response as well. Has a lot of experience around the world, and he's one of the owners and founders of the company, and he is the corporate medical officer for the company. Scott Giverson just joined us. He's a retired Rear Admiral out of the public health, U.S. Public Health Service. He was a assistant U.S. Surgeon General for 11 years and then a deputy Surgeon General for 2 years. He has leadership roles in the company and, provides a lot of advice to us as well. And then I know that John and Tony coming out of the Maclean group, we're very happy to be working with them, and those guys are providing us with all our medical supplies on the LA USD project. Next slide, please. Well, Los Angeles Times came out with an article early this week, I think it was Monday or Tuesday, and in it was mentioned, AMI and Summer Bio. I hope that everyone got a chance to read it. Anyway, I'd like to thank you all for your time, and we're here ready to answer any questions. I'd like to turn it back over to James Collins now.
All right, thank you so much. We appreciate it. Thank you so much to our presenters. We will now enter the question and answer segment of the webinar. I do have some pre-submitted questions that were sent to us, team, and so I'll just go down that list. There's about 7 questions. So the first one here is, at what point would it be time to test a student or employee?
You want to take that one?
Yes, I would recommend the way we usually do it is do what we call a baseline testing before schools are opened up. So what you do 2 weeks or 3 weeks, depending on the number of students and staff you have, you get everybody to come to whether it's the school or however you designed your testing to be performed. A week or 2 prior to that, get everybody tested, get the baseline. You quarantine those who are positive, those who are negative, continue to come to school on the first day. And then that first week of school opening, you again repeat the testing. And depending on the prevalence and the positivity rate at that current time, we would recommend weekly versus bi-weekly testing to capture all asymptomatic and or symptomatic cases within the school system.
Okay, perfect. Can tests that use the check swab be used? Is this less invasive?
Yeah, so the test swab that we utilize is an anterior mid-turbinate. It's not a nasopharyngeal where most people don't really like at all, where it touches your brain. So we've used it across all of LAUSD. It's very easy to use. We also utilize a saliva test for those who cannot tolerate anything in their nose, or whether it's a medical condition for whatever reason. We offer both of those.
All right, my apologies. Cheek, not check. I misread that. So do we have any testing guidance for student athletes?
We go based on what our customer needs are, but essentially what I can tell you, what we have done for universities and other school systems we utilize is before match day, whatever the game may be, a day or two prior to the actual game, we bring all the athletes to the school and or a static site that we created for testing, and we test all athletes before the game so that you can have results the day before they actually start the game.
Got it. I have one that came through. How often do the filters need to be changed on the Delos units, and what is the cost per filter?
Sorry, guys.
There you go.
Yeah, can you hear me okay?
Yes.
Okay, good. The great thing about these filters is the low maintenance. You're talking about a 1-year annual filter change. So once a year filter replacement. The cost is on and around $100. I'll get you the exact price, but it's a relatively low cost, and it's an easy maintenance cycle.
Perfect, thanks. At what levels of spread should 1-time or 2-time screening testing be implemented? Universal, statistical, pooled, with size?
Again, we typically go based on CDC guidelines, and currently CDC guidelines said the cutoff mark for stopping pooled testing is around 5%. But if you go based on Mayo Clinic's recommendation, they say 2%. And currently the positivity rate will determine how often you do the staff and or student testing. I think once weekly is pretty decent for now. If you're at a higher percentage rate, let's just say more than 30%, I would recommend twice weekly testing for all members. But if you're less than the 20% mark, I think once a week testing is appropriate at that time.
Got it. One that came through, this may be more addressed maybe to you, Tony, but how do basically all the folks on the screen, how do your teams work together? How does everything kind of come together?
Yeah, it's a great question. So Maclean has been around for multiple years. We currently have the California State contract unmasked. Specifically, with each vendor, we do a rigorous background review. So when we distribute products, for instance, Delos, we have been in active discussions with them for almost a year now, and so their track record speaks for themselves. And so when we're partnering with organizations, we look for the highest quality and the highest standard. In regards to AMI, we were introduced through a group of people that we are medical professionals, and did the same rigorous background check and saw that they were with the LA Unified and wanted to partner with them in business development and operations role.
Got it. The mandate requires weekly testing. We want to assign our employees a particular day each week. Must we provide flexibility?
We're adaptable. So usually what we do is the teams are readily available at each site to capture anybody that's missed and or people who need to get a baseline or they're symptomatic. So yes, we are flexible, but usually, especially in schools, it's going to be depending on the date that your school is serviced. But what we try to do, especially if there's a lot of changes and or scheduling changes, we provide at least one person at that school every day to ensure that everybody gets tested.
Got it. Does Summer Bio work with Track My Solutions?
It does not right now.
Okay. What funding is available for test kits?
I think that FEMA extended the tenets of the CARES Act, but I'm not super familiar with the process of how the funding is asked for by the counties. We could do some research on it to find out, but typically we're not involved in that part of the process.
Okay. How will LEAs be held accountable to comply with governor's mandate that teachers must be vaccinated or have weekly COVID tests?
Say again, please,
Yes, sorry.
James?
Yes. How will LEAs be held accountable to comply with governor's mandate that teachers must be vaccinated or have weekly COVID tests?
What's an LEA?
Yes, we don't know what it is.
Yeah, so LEAs are basically our members, our school districts.
Okay. I don't think that's something that we can answer. I think that's more that the organization.
And I'll own that. I'll own that. I'll work with our legal to get the answer out on that. I probably should have avoided that one, but I'll get that one out to the group because that's a little bit more legislation driven. Are there tools out there to help track positive cases and keep track of return dates after quarantine based on guidelines?
Yes, of course. Usually what we utilize is the contact tracers within the community that are already part of the school system. And we, our team, along with the contact tracers, determine who's positive, and then we take them out and quarantine them. And depending on whether it's a symptomatic based isolation versus just an asymptomatic positive rate, we usually do about 10 days of isolation prior to return to work. But yes, so we, along with our customers, are actively involved in that process.
And also, we have a call center that was extremely effective in Pennsylvania in order to reach out to those that were positive and give them guidance. We have RN staffing, the call center, and also we used it very effectively, especially in the early days of vaccinations to, provide information to folks and make sure they got to the right place at the right time.
Got it. What types of services and products would you recommend for a small district in an area with increased Delta variant cases? This could probably be anybody on this one, but basically I'll ask it again. What types of services and products would you recommend for a small district in an area with increased Delta variant cases?
In terms of testing, I would definitely recommend individual PCR testing. The frequency, of course, will depend on the institution and or the school or the community with their healthcare professionals, but I would recommend at least within the school buildings and or office building, once weekly PCR individual testing.
And for those programs, they can be adapted, and we work closely with the customer to define what the requirements are so that we're just, we're tailored exactly for that, so you're not overspending for a service that you don't need.
Yeah, anybody want to add to that, or are we good on that?
Yeah, I mean, look, I would just say small district, large district, doesn't matter. Localized filtration is obviously another way to ensure or help ensure that you're doing everything you can to reduce where transmission is occurring. So ordering 1, 10, 20, 50, or 20,000 units all at the same mechanism is doesn't matter how the size of the district, obviously.
Got it. Let me just find here another one. This one is a little bit of a long one. This may be for you, Paul. Have you done a cost versus benefit analysis of bumping filters to MERV 16 or above and updating blowers of existing air handlers in schools to overcome the additional pressure drop? And how would that compare to the localized portable air filtration solution in terms of effectiveness, basically long-term ROI? Probably heard this before.
Good, great question. Nothing compares to localization. You can do whatever you want in the duct, get to MERV 16 even, and obviously that's going to be an energy issue. But even in doing so, the air's got to travel all the way across the room to that one source of filtration to get filtered. A lot of contagion can happen in the meantime. So nothing will compare to localizing filtration. Using standalone units that are long-term solutions, 10 plus years and running, but using standalone units gets you to MERV 20 with zero energy load in terms of a pressure drop in the duct. So I would say go as far as you can without too much of a strain on the system in the duct, but don't over-engineer that. All you need to do is supplement that with localized filtration, and you've got an amazing outcome.
Got it. This next one, we may be able to answer some of it, but it could be also something I need to look into. But in California, the mandate for schools require only non-vaccinated staff need to be tested weekly. Do we still need to quarantine staff if they test positive but have no symptoms?
I'm sorry, James, can you repeat that question?
Yes. In California, the mandate for schools is to require only non-vaccinated staff need to be tested weekly. Do we still need to quarantine staff if they test positive but have no symptoms?
I would highly recommend you quarantine any asymptomatic individual who tests positive. Just because they're not symptomatic does not mean they're not able to spread the disease. And actually, articles and research is coming out within the last couple of days about the Delta variant, especially in vaccinated people. It's just, we can spread it, those who are vaccinated, I'm talking about myself because I'm vaccinated, we can spread it just as easily as an unvaccinated person. And depending on California's law saying only unvaccinated need to be tested, that does not mean you do not test people who are vaccinated, especially in light of new research that says all of us, even vaccinated, can be carriers of COVID-19 and spread it to people who may be immunocompromised or at risk for severe disease.
Got it. Wow, we're at the top of the hour and we got all the questions. I don't see any others that came through. We've answered it. And I just want to thank all of you for joining us today, especially those who contribute to the questions. CSBA is dedicated to providing up-to-date resources to school board members. To view our recent webinars, be sure to check out our YouTube page at youtube.com/CSBA video. If you're interested in attending future CSBA webinars, please go to our website at www.csba.org/webinars to register for upcoming webinars. Today's recording and slide deck will be available to view on our webinars page by tomorrow afternoon. Many thanks to our presenters. Thanks, Tony. Thanks, team. I know we put this together pretty quickly, but this is very, very important initiative across our state and obviously across the nation. So many thanks. And with that, I'll see you next time.
Thank you.
Thank you.